Assalamu alaikum everybody. I hope you are in good health and prosperity. My name is Abdullah Salim Elhwuegi. I would like to welcome you to my Principles of Pharmacology, where we are talking about drugs acting on the central nervous system. In today's presentation, inshallah, we'll talk about sedative-hypnotics, including the most famous barbiturates and barbiturate-like drugs. These barbiturates and barbiturate-like drugs, they belong to a group of drugs that are known as non-specific C.N.S depressants. Non-specific C.N.S depressants, they are drugs which produces dose-dependent C.N.S depression. Dose-dependent C.N.S depression. At low doses, these drugs will produce sedation, a calming effect. This sedation usually is accompanied by removal of anxiety or anxiolysis. Anxiolysis means removal of anxiety. If we increase the dose of these drugs, they can produce hypnosis, they can induce sleep, the person will become asleep. And if we increase the dose more, this sleep is accompanied by general anesthesia or loss of consciousness. Okay? Now, if we increase the dose more, these drugs are able to produce medullary paralysis. And as we have said before, medullary paralysis means death due to depression of the respiratory and cardiovascular system. Okay? These non-specific CNS depressants includes many groups of drugs like general anesthetics, which we talked about in the last presentation, and the barbiturates and barbiturate-like drugs like chloral hydrate, and the benzodiazepines, which we'll talk about inshallah in details when we talk about anxiolytics. Okay? So these drugs, they produce different stages, as you can see, depending on the dose. If we plot the relationship between the response and the dose, we have said that at low doses they can produce sedation. If we increase the dose, they can produce hypnosis. And if we increase the dose further, they can produce general anesthesia and lastly, medullary paralysis. Some drugs like barbiturates, they produce straight dose response curve. As you can see here, as you increase the dose, you will transfer the patient from one stage to another. So at the very beginning, sedation will take place, followed by hypnosis, then general anesthesia, and finally medullary paralysis. This happens with barbiturate-like drugs. Barbiturates-like drugs like ethanol, like meprobamate, like chloral hydrate, etc., as we will discuss later, inshallah. Other drugs like benzodiazepines, they can never produce general anesthesia. So at the beginning, they can produce sedation at low doses. And if you increase the dose, you'll get hypnosis. The person will go into sleep. But then the dose response curve becomes flat. And there is no increase in the response. There is no general anesthesia. This includes the benzodiazepines that we will discuss later, inshallah, when we talk about mental illnesses. Okay? There are other group of drugs which produces very little sedation, but they produce very strong anti-anxiety effect, like Byrons, which are known as Byrons, like Buzz-Byron, like the Ipsa-Byron, that we'll talk about them, inshallah, when we talk about anxiolytics, inshallah, okay? So now these drugs, they can produce non-specific barbiturate-like, they can produce non-specific CNS depression, which can end up in medullary paralysis. So what are the main goals of this presentation? What we are looking for? What are the main objectives of this presentation? So as we have said, we are talking about the sedative hypnotics. First, we'll talk about their classification, how they are classified according to their chemical structure. Then we'll talk about the barbiturates in general, and more specifically on their mechanism of action, on their pharmacokinetic profiles, on their pharmacological actions on different organs in the body. Then we'll talk about their tolerance and dependence. There are a group of drugs that they can produce tolerance and dependence. And lastly, we'll talk about their clinical application. The other group which we'll talk about in brief are the non-barbiturates. The non-barbiturates, in this case, they resemble barbiturates in all their action, except they are of different chemical nature. Okay, so these are the main objectives. This is the learning goals, what we are looking for. So first we'll talk about the classification of sedative hypnotics. As we have said, they belong to barbiturates as a group, which are derivatives of barbituric acid, as we will see later, and the non-barbiturates or barbiturate-like, which resembles exactly the barbiturates except they are of different chemical structure. And lastly, the benzodiazepines, and the benzodiazepines, as I have said, we will talk about them when we talk about anxiolytics or anti-anxiety drugs. So our main lecture will be about the barbiturates and barbiturate-like drugs except the benzodiazepines. The barbiturates are classified according to their duration of action into ultra-short-acting barbiturates. Ultra-short-acting, why? Because they produce very short duration of action, which lasts from 10 to 15 minutes. This group, we talked about them when we talked about the intravenous general anesthetic. The most famous examples are the thiamycin and the thiobentone. Thiobentone, as you know, is the British or the English name, and in North America it is known as thiobental. Thiobental, it is the same thing. Okay. A second group of barbiturates, they are known as short-acting barbiturates. Short-acting because they act from 2 to 3 hours, like secobarbital or secobarbital. Secobarbital, as I said, the British name. Secobarbital is the North American name. And these usually short-acting, they are used as pre-anesthetic medication to induce a night's sleep before anesthesia. A third group are the intermediate acting, like aminobarbital, or amylobarbital, it is the same thing, amylobarbital, or the phenobarbital or phenobarbital, and these they act for up to 8 hours, and they were used one time in treatment of anxiety as anxiolytics, but now they are not used anymore because of their disadvantage of tolerance, dependence, and toxicity. Last group is the long-acting barbiturates, and the most famous examples for phenobarbital or phenobarbital, the same thing, phenobarbital or phenobarbital, and these they have a long duration of action up to 24 hours, and it is mainly used as anti-epileptic drug in treatment of epilepsy, as we will see later. Okay. So these are the classification of the barbiturates. They are classified according to their duration of action. How the barbiturates they produce depression of the central nervous system? The barbiturates they act through the GABA system, which is the GABA amino butyric acid, which is known as GABA. And as we have said before, GABA is a specific C.N.S neurotransmitter which acts on 3 different types of receptor: GABA-A, GABA-B, and GABA-C. Barbiturates they act on the GABA-A receptor, on the gamma aminobutyric acid A type receptor. In GABA-A receptors, they are ionotropic receptor and they are pentameric. Ionotropic, that means they are linked to ion channels, or pentameric, that means they are formed from 5 subunits. As we can see here, this is the GABA-A receptor macromolecules. It is known as macromolecules. Macro because it is macromolecule, because it is relatively large in size. It's known as macromolecule, GABA macromolecule. It is relatively large protein composed of 5 subunits, 2 alpha, as you can see here, 2 beta, and gamma subunits. These subunits, they enclose the chloride channel, as you can see. They enclose the chloride channel. That's why it is known as ionotropic receptor. Ionotropic because it is linked to chloride channel. And it is pentameric because it is composed of 5 subunits. As you can see, the binding site for the GABA is at the alpha subunit and the beta subunit. So the GABA molecule will bind to these 2 subunits to open the chloride channel. Once the GABA binds to these subunits, these 2 subunits, chloride channel will open and chloride will rush into the cell. Chloride, as we know, is negatively charged. Once it enters the cell, it will increase negativity of the intracellular of the cytoplasm, and this will result in hyperpolarization. Hyperpolarization, as we have discussed several times before. And hyperpolarization, what does it mean? It means inhibition. It means inhibition. Why? Because in this case, the neuron is inhibited because it needs a stronger stimulus to be stimulated. Okay? That's why they produces inhibition. So GABA receptors, they are located on the alpha and beta subunit, and the GABA molecule should bind to these two subunits. Once it binds to these subunits, it will open chloride channel. Chloride will rush into the cell, increasing the negativity inside the cytoplasm or negativity of the inner membrane, and this will result in hyperpolarization. Hyperpolarization, as we have discussed, it means inhibition. In general, it means inhibition because the neuron needs a stronger stimuli to be stimulated. Okay? So this GABA A receptor or GABA receptor, they are known as orthosteric binding site. Orthosteric binding site. What does it mean, orthosteric? It means that they bind the GABA and GABA-like drugs. GABA mimetics. GABA mimetics, which we called them before GABA mimetics or GABA-like drugs. GABA mimetics. Okay? So once GABA binds to its receptor on the alpha and beta subunit, and it should bind to both of these. If it binds to one, it doesn't produce an action. Like once it binds to these two, the molecule itself binds to these two subunits, then chloride channel will open, chloride will rush in, causing hyperpolarization of the membrane. A neuronal membrane becomes hyperpolarized. That means inhibition. Okay? This binding site is known as orthosteric binding site, specific for GABA mimetics. Okay? Also, the GABA macromolecule, it contains other allosteric binding site. Allosteric, that means they are binding site other than for GABA. Allosteric binding site, what does it mean? They are receptors for other drugs other than the GABA mimetics. Okay? They are known as allosteric. Allosteric binding site, they bind other drugs other than the GABA itself. These allosteric binding sites, they are receptors, of course. They are receptors like barbiturate receptor. These are the barbiturate receptor. If the barbiturate receptors, they are allocated on the GABA macromolecules, and they are known as allosteric binding site. Allosteric meaning the receptor which binds everything, other drugs other than the GABA mimetic. Okay. Also, there are other allosteric binding sites for other drugs like benzodiazepines, like bicrotoxin. It is not there, like zolpidem and other drugs. Yet the macromolecules, it contains orthosteric binding site, which are the GABA receptors, or which binds only GABA mimetics, GABA-like drugs. Okay? And the macromolecules, it contains other allosteric binding sites. Well, allosteric binding sites are receptors which binds other things other than the GABA itself. Like there are specific receptors for barbiturate, and there are other allosteric binding sites for the benzodiazepines, for the flomazanil, as we will see later. This is benzodiazepine antagonist, like zolpidem, which is anxiolytic. Okay? So this is the difference between the orthosteric binding site and the allosteric binding site. Okay? Now, so what will happen? So as I have said, GABA will bind to the alpha and beta subunit, and this will result in opening of chloride channel, and chloride will rush in, causing hyperpolarization. So what will happen when the barbiturate molecule binds to its receptor? The same thing, barbiturate will bind on two binding sites present on the alpha subunit and the beta subunit. Okay? No, so the barbiturate binds to two binding sites. Barbiturate molecule, It binds to two binding sites on the barbiturate receptor. These binding sites are located on the alpha and the beta. Once the barbiturate binds to its receptor, what does it do? شنو يدير؟ Once the barbiturate binds to its receptor and the GABA as well binds to its receptor, the frequency of opening of chloride channel will be increased. Just let us take an example. If the GABA binds to its receptor, say, for example, it will open chloride channel 100 times. Okay? So one molecule of GABA binds to its receptor, it will open the chloride channel 100 times. In the presence of barbiturate, the chloride channel will open for 150 times. The frequency of opening will be increased. The opening, instead of 100 times, it will open for 150 times. So the frequency of opening of chloride channel will be increased in the presence of barbiturate. What does this mean? شنو يعني هذا؟ يعني إن hyperpolarization will be more, because if the GABA is alone, it will open the chloride channel 100 times, but in presence of barbiturate, it will open it 150 times. That means the amount of chloride entering the neuron will be more. That means more hyperpolarization. معناها means more inhibition. Okay? يبدأ this is clear. Okay? This happens at the low doses of barbiturates. في low doses of barbiturates. يعني doses which can produce sedation and hypnosis. Okay? But if we increase the dose to the dose that can produce general anesthesia up, when increase the dose to the dose which can produce general anesthesia, barbiturate will open chloride channels by themselves, even in the absence of GABA. So at high doses which can produce general anesthesia, what the barbiturate do? The barbiturates will open chloride channels by themselves. They become GABA independent. معناها they can open the chloride channel. Opening the chloride channel معناها they can produce inhibition even in the absence of GABA. This is why they can produce general anesthesia in the high dose. They can open the chloride channels by themselves, even in the absence of GABA. Okay? يبدأ we start from the beginning. The barbiturates, they bind to their own receptors present in the alpha and beta subunit. This binding will result in increase in frequency of chloride channel opening, معناها more hypolarization, معناها more inhibition. Okay? This takes place in the low doses of barbiturates that produces sedation and hypnosis. But if we increase the dose of barbiturates in this case, they can open the chloride channel by themselves, independent of the presence of GABA. في الحالة هذه, what will happen? They produce depression, non-specific depression of the central nervous system. Okay, so this what happens with barbiturates. They bind to barbiturate binding site. For small doses, they increase the frequency of chloride channel opening, and in this case, they produce more hyperpolarization. In large doses, for high doses, they can open chloride channel by themselves, even in the absence of GABA. So this is the mechanism of action of barbiturates. They act through the GABA system, or GABA-A receptor. By this action depends on the dose. For small dose, they increase the frequency of chloride channel. For large dose, they can open the chloride channel even in the absence of GABA. This will differentiate the effect of barbiturates from the benzodiazepines. The benzodiazepines, they can never produce opening of chloride channel by themselves. They are different. Okay, that's why benzodiazepines, they can never produce a general anesthesia. Why? Because they cannot open the chloride channel in the absence of GABA. They act only in the presence of GABA. That's why benzodiazepines, they have more specific action than the barbiturates. Okay, so this is the mechanism of actions of barbiturates, which is the most important. So barbiturates, I repeat that, in small doses they can increase the frequency of chloride channel produced by GABA. In large doses, they can open the chloride channels by themselves, and this will lead to non-specific C.N.S depression. Okay. Next, we'll talk about the pharmacokinetic properties of barbiturates. Barbiturates, they have very specific pharmacokinetic property. About the absorption and distribution, they are highly lipid soluble. So what we expect if they are highly lipid soluble, they will be absorbed fast, produce fast onset. الonset of action هيكون fast onset هيكون fast. وكذلك they will be distributed fast to the brain. They will enter the brain fast because they have high lipid solubility. As we have said, drugs which have high lipid solubility can have a quick access to the brain. Also, they have high plasma protein binding, once especially for phenobarbital. Phenobarbital, it has high phenobarbital, which is, we said, it has a long duration of action. Phenobarbital, it has high plasma protein binding, and in this case, it will act as a site of interaction with other drugs when other drugs that are taken at the same time. Okay? So how they are eliminated from the body? They are eliminated by process of metabolism, because as we have said, they are highly lipid soluble, and as we have said in the introduction about the pharmacokinetic, we said any lipid soluble drug should be metabolized before it can be excreted in the urine. So this applies to barbiturates. They are metabolized in the liver by the process of oxidation, and this is usually done by the liver microsomal enzymes, especially cytochrome B450 enzymes. The barbiturates, they are known of inducing the liver microsomal enzymes. Inducer means they increase the activity, they increase the activity and the concentration of the liver microsomal enzymes. What does this mean? It means that they increase the metabolism of the barbiturates and as well other drugs which are metabolized by the same enzyme system. Okay, you have the barbiturates, they are strong enzyme inducer. So what will happen if I take barbiturates for a long period of time? That means the enzyme will become more active and more in concentration. That means that the barbiturates will be metabolized faster. That means faster elimination. This will result in end of the effect earlier, and this will result in loss of effect, which is known as metabolic tolerance. Therefore, barbiturates, they are known of producing metabolic tolerance. If somebody asks you, why the barbiturates they produce metabolic tolerance? Because they are enzyme inducers. They increase the activity and the concentration of the microsomal enzymes, and this will result in faster metabolism of barbiturates, i.e. faster elimination, i.e. faster loss of action, and this is known as metabolic tolerance. Metabolite طبعا after oxidation it is conjugated in the liver through phase 2 metabolism. After it, the conjugated part and some of the ionized part excreted unchanged in the through the kidney. You have the renal excretion. Usually, phenobarbital, it is only the phenobarbital, about 20 to 50% of phenobarbital is excreted in the kidney unchanged, together with the metabolite of phenobarbital, which is oxidized in the liver. That's why, because phenobarbital is acidic. If we make the urine alkaline, that means most of it will be stay in the ionized state, and therefore it will be excreted. As we have said in introduction to pharmacokinetic, we said acidic drugs, they will be mostly ionized in alkaline urine, and therefore this will increase their excretion. Because as we have said before, the renal excretion depends on the ionized fraction. If the drug is an ionized fraction, it cannot be reabsorbed. It cannot cross biological membrane, and therefore it will be excreted. Okay, so alkalinization of the urine will increase the renal excretion, especially this is done in overtoxicity with phenobarbital. Okay, these are the pharmacokinetic properties of barbiturates. What I should remember, they have high lipid solubility, therefore they will have quick access to the brain, and because of high lipid solubility, they must be metabolized in the liver by oxidation, liver microsomal enzyme. They are strong inducers of this enzyme. They increase the activity and the concentration of the enzyme, and this will result in faster metabolism when they are taken for a long period of time, and this is one of the causes of the metabolic tolerance, as we will see. Once they are excreted in the urine, the free ionized fraction will be excreted through the urine and the metabolite as well. As I have said, they are acidic. Therefore, alkalization of the urine, making the urine alkaline, will increase their renal excretion because in this case they will be present mostly as ionized. Voila, okay? If this is the pharmacokinetic property. Pharmacodynamic property will start with the action on the central nervous system. As I have said, they produce dose-dependent depression of the central nervous system, and this starts with sedation, and this sedation usually is accompanied by euphoria. Euphoria. What does it mean, euphoria? Feeling of happiness. Feeling of happiness, removal of stress, removal of anxiety. So it is a pleasant pleasant feeling, and that's why many people they abuse barbiturates. Why? Because they give them a false feeling of happiness. Okay, this is known as euphoria. Euphoria. If we increase the dose, they can produce hypnosis, followed by general anesthesia, followed by coma and death. Okay. Also, they produce dose-dependent inhibition of the central nervous system, starting from sedation to death. The dangers of barbiturates, they have small therapeutic index. The difference between the dose that produce sedation and the dose that can produce coma and death is small. Maybe 4 to 5 times the dose can enter the patient into coma and death. Yani either by accidental or by tension, and the person will take 4 to 5 times the dose, it can produce death. This is why one of the reasons why barbiturates are not favored anymore in therapy. Why? Because they have a small therapeutic index. The difference between the dose that can produce sedation and death is small. واضح? The second effect, they depress rapid eye movement sleep. Rapid eye movement sleep. Well, rapid eye movement sleep, it is a stage of a sleep. It is a stage of the sleep. Let me explain that in details, inshallah. So, if the person is awake, his brain activity, the person when he's awake, his brain activity measured by electroencephalograph, this is EEG or electroencephalograph. When the person is awake, his brain activity shows low voltage, high frequency activity, as you can see here. Low voltage, high frequency activity. This is when the person is awake. Like, once the person will become calm and tries to go to sleep, in this case, it will enter first into stage 1. Stage 1. Stage 1, usually the voltage is still low, but it is with mixed frequency, with high and low frequency. This is stage 1, when the person comes sedated. If the person goes further into sleep, he will enter into stage 2. Stage 2. Stage 2 is different. It shows sleep spindles plus K complex. Once the person stays in sleep, he goes into deep sleep, which is known as stage 4. In deep sleep, the waves will become slow, as you can see. Slow waves, high voltage, not low. Slow wave, slow, frequency is slow, not fast, and high voltage, okay? This is deep sleep. This is known as the deep sleep. So the person, when he's awake, his brain activity will show low voltage, high frequency. Once he goes into different stages of sleep till he reaches the deep sleep stage, his brain activity will show high voltage, low frequency waves. So once the person enters into the deep sleep, he will stay in stage 4 or deep sleep for a certain period of time. Then his brain activity will show light sleep, will show stage 1 activity, low voltage, mixed frequency, stage 1 activity. The person is actually still in sleep, but his brain activity show the reverse. That's why this stage is known as paradoxical sleep. Paradoxical sleep. Paradoxical sleep. Or rapid eye movement sleep. Rapid eye movement. And in this case, the eye will show rapid movement. That's why it's known as REM sleep or paradoxical sleep. In this stage, usually dreams takes place. Usually dreams, whether they are good dreams or bad dreams, or nightmares, usually they take place in the REM sleep, okay? Then the person will go back into deep sleep. His brain activity will show stage 4, which will continue for a certain period of time. Then it goes back into paradoxical sleep, and so on all over the night. So all over the night, as you can see, a person will have about 4 to 5 stages of REM sleep or paradoxical sleep. They found that these REM sleep, they are important for the normal function of the body. So what the barbiturate does, the barbiturate, they depress the REM sleep. What does it mean? It means the person will stay in stage 4 for a long period of time. You will have no REM sleep, or they will have less number of REM sleep. Instead of 4 to 5 times, we will have 1 to 2 times REM sleep, and the rest in deep sleep. Of course, this will not be liked by the body, will not be liked. So what will happen? What will happen? The body will try to compensate by increasing the number of REM sleep. So number of REM sleep will be increased. So normally there are 4. For normal cases, there are 4. For example, REM sleep. When I start taking the barbiturates for a long period of time, become 2 REM sleep. The body will not like that. So what the body will do, it will increase the number of REM sleep to 4 to return it to normal. Okay? Now, if I stop taking the barbiturate, what will happen? Stop taking the barbiturate. Instead of having 4 times REM sleep, I will have 6 REM sleep, as I have said. Of course, 6 REM sleep معناها more dreams. And these dreams, some of them, they are bad dreams, they are nightmares. So what will happen in this case? What the person will do? He will not like that. So he will return taking the barbiturate again. He will return taking the barbiturate again. And this will lead to a state of dependence. Okay? So the barbiturates, what they do? They depress the REM sleep. The number of REM sleep per night will be decreased. The body will not like that. So what the body will do, it will increase the REM sleep to return it to normal. Okay. Once the person stop taking the barbiturates, what will happen? His REM sleep will become more. Some of these REM sleep, زي ما قلنا, dreams takes place in the REM sleep. So what will happen in this case? The person will suffer from many nightmares. So what will happen? He will go back taking the barbiturates, i.e. he will become dependent on the barbiturates. This is one of the suggested mechanisms for the development of dependence to barbiturates. Okay? Barbiturates in high doses, they can depress the respiratory centers, as we have said, in the medulla, and this will result in medullary paralysis. This effect is most dangerous in people who are already suffering from obstructive pulmonary diseases like bronchial asthma, like pulmonary emphysema, etc. Also in high doses, it can depress the vasomotor center, and this is most dangerous when the person is suffering from hypovolemia. For example, when the person is exposed to bleeding, severe bleeding, if I give him barbiturates in this case, he might enter into shock because of this combination of effect. Okay? The barbiturates, they are known, they have beneficial effect on the cerebral blood flow. They decrease intracerebral pressure by decreasing or lowering cerebral metabolic demand. And as we have said before, lowering the cerebral metabolic demand means to protect neurons against ischemia. Lowering cerebral metabolic demand, if there is ischemia in the brain or decrease in the blood supply, oxygen supply to the brain, in this case, the barbiturates will prevent the ischemia, to protect the neurons against ischemia. Why? Because they will decrease the metabolic demand. By decreasing the metabolic demand, they will decrease the chance of ischemia. This is a good effect of barbiturates. Of course, the barbiturates, they are hyperalgesic. They increase the sensation of pain. They are hyperalgesic. They increase the sensation of pain. Also, centrally, they inhibit the spread of epilepsy. They inhibit spread of epilepsy. As we will see, inshallah, when we talk about the antiepileptic drugs, usually epilepsy, it spreads from one part of the brain to the other through certain waves. This spreading is inhibited by barbiturates, and that's why they are used as antiepileptics, certain types of epilepsy, which is known as anticonvulsants. Okay. These are the central nervous system effect. On the respiratory nervous system, on normal person, they have little effect. Like most dangerous, as we have said, when they are used in people who are suffering from pulmonary diseases like bronchial asthma, like bronchial emphysema, etc. Toxic doses, of course, they can depress respiration, which is usually central effect. On cardiovascular system, the same thing. Normally, for a normal person, they have little effect. ولكن in people who are suffering from hypovolemia can lead to shock, as I have explained. The toxic effect they can lead to cardiac arrest due to inhibition of the cardiac centers in the medulla. وكذلك they can lead to severe shock due to vasomotor collapse. One of the disadvantages of barbiturates when they are taken for a long period of time, that they can produce tolerance and dependence. What does it mean, tolerance? Tolerance means disappearance of the initial effect. That means the person takes a certain dose to get certain effect. After repeating the same dose after a certain period of time, he will not get the same effect. He will get less effect. The effect will be less. So what the person will do, he will increase the dose to get the same effect. وهكذا. Every time the patient will increase the dose gradually, but to get the same effect. This is tolerance. بالعربي التحمل. يعني الجسم ابتدى يتحمل تأثير الدواء. So what will happen in tolerance? Tolerance might be caused by metabolic tolerance or pharmacokinetic tolerance, which is known as metabolic tolerance. This, as we have explained, is due to increase in metabolism of barbiturates. Then, as we have said, barbiturates, they are enzyme inducers. So after taking them for a long period of time, what will happen? The enzyme will become more in concentration and activity, and it will start metabolizing the drug faster, and the drug will be eliminated from the body faster, and this will result in less effect. This is known as pharmacokinetic or metabolic tolerance. Pharmacokinetic or metabolic tolerance. A tolerance can be central, pharmacodynamic tolerance, central or pharmacodynamic tolerance. What does it mean? إن يحصل central adaptation to the presence of the drug. The brain will behave in a certain way to decrease the effect of the drug. This is known as pharmacodynamic tolerance. يبدأ pharmacodynamic tolerance and pharmacokinetic tolerance to barbiturates is very common. If the person will increase the dose gradually and continuously. This tolerance, usually there is a cross tolerance between barbiturates and non-barbiturates. For example, if the person is taking ethanol chronically, alcohol, الخمر, الناس اللي تشرب في الخمر, usually they need a larger dose of barbiturates. Why? Because there is a cross tolerance between ethanol and barbiturates. وكذلك as well with other barbiturate-like drugs. Okay? This tolerance is not complete. It is known as partial tolerance or incomplete tolerance. What does it mean? يعني يحصل tolerance للأيوفيريك effect ولكن ما يحصلش tolerance للميدلري paralysis. يحصل tolerance للأيوفوريا. Tolerance to the euphoria. إن person will lose getting the euphoria. ولكن tolerance to the medullary paralysis will not take place. So what will happen in this case? That's why it's known as incomplete tolerance. So what will happen? The person will start increasing the dose slowly, increase the dose, increase the dose, increase the dose to get the euphoria, of course, till he reaches the dose that produces medullary paralysis. So what will happen in this case? Death. What will happen in this case? Death. So at the beginning, he's getting euphoria with a small dose. Then after a certain period of time, this euphoria will not be felt. So he will increase the dose and gradually increase the doses to get the euphoria till he reaches the dose that produces medullary paralysis and death. Anyway, يبدأ this is a partial tolerance, incomplete tolerance. يبدأ what does it mean tolerance? Tolerance means disappearance of the effect after repeated administration of the drug, which might be a pharmacokinetic or a pharmacodynamic tolerance. And we have said that there is a cross tolerance between the barbiturates and non-barbiturates, like alcohol, like chloral hydrate, etc. And this tolerance is not complete, it is incomplete tolerance. Why incomplete? Because tolerance will take place for some of the actions of barbiturates, but not to the medullary paralysis. معناها we increase the dose slowly till we reach the dose that can produce medullary paralysis and death. This is tolerance. Dependence means the body or the person will become dependent on the drug. معتمد. Dependence بالعربي اسمها اعتماد. الإنسان يبدأ معتمد على الدواء. الاعتماد dependence. Okay? يبدأ dependence, the person will become dependent on the drug. This dependence might be of two, psychological dependence or physical dependence. Psychological نفسي, اعتماد نفسي. معناها the person will like, for example, the euphoric effect. Psychological, a person will like euphoric effect. He wants to experience the euphoric effect again and again. So what will happen? He will become dependent on the drug. He'll try to find the drug by any way because he likes the euphoric effect. واضح الكلام? This is known as psychological dependence. Second type of dependence is known as the physical dependence. The physical dependence, what does it mean? It means that the brain or the central nervous system will consider barbiturates as an important constituent. So what will happen in this case? If I stop taking the barbiturates, an excitation of the central nervous system will take place, which is known as withdrawal syndrome. Withdrawal syndrome, usually there is an increased anxiety, insomnia, C.N.S excitability, which can end up in convulsion. And this convulsion usually, it is very dangerous convulsion. It can lead to death. That's why the withdrawal from barbiturates, it is very dangerous. And this is one of the causes of limitation for the long-term use of barbiturates. Okay? So dependence, as we have said, it might be a psychological dependence where the person will like the euphoric effect of the drug, or it might be a physical dependence. In this case, physical dependence, the body will consider the barbiturate as a normal constituent. Once I stop the barbiturates, that means excitation of the central nervous system will take place. This is known as withdrawal syndrome. Withdrawal syndrome, it resembles withdrawal symptoms from ethanol. It can produce increased anxiety. The person will become قلق. قلق is that. Insomnia, of course, because barbiturates, they were producing sleep, so insomnia, and CNS excitation, which can end up into convulsion. So this is one of the limitations of barbiturates, why they are not commonly used nowadays, because they can produce tolerance and dependence. Okay, so the barbiturates, they have a narrow therapeutic index, they can produce a drug-drug interaction, they can produce tolerance and dependence. So their clinical use is very limited because, as I have said, they have a narrow therapeutic index. They can produce drug-drug interaction, and as well they can produce dependence liability. But they have very important clinical use as intravenous general anesthetic, like a thiamycin, like a thiopental, and we discussed that before. Also, they are used as pre-anesthetic medication like stecobarbital, which is given the night before the operation to give the person a night's sleep. Also, they are used as antiepileptic like phenobarbital. It is used in treatment of certain types of status epilepticus as second choice drug, as we will see later. Also, they are used in barbiturates to produce strong sedation in cases of necroanalysis, which is known as necroanalysis. Okay. Lastly, phenobarbital is used in treatment of bilirubin. Sometimes the neonates, when they are born, they have a high bilirubin in the blood, and they found that phenobarbital, when they give phenobarbital, they conjugate the bilirubin and they decrease the bilirubin level in the blood. This is a highly specific use, and it is done under very close medical supervision. Okay, so these are the clinical uses of non-barbiturates. The second group of sedative hypnotics, they are known as non-barbiturate sedative hypnotic. They are known as non-barbiturates because structurally they are not barbiturates, they are not derivatives of barbituric acid. And this includes the most famous chloral hydrate. Chloral hydrate, this is the oldest. And this is the drug which was abused by Van Gogh, famous painter. He died from an overdose from chloral hydrate. And it is metabolized in the body to trichloroethanol, which is, of course, ethanol. Chloral hydrate now it has very limited use in procedural sedation, sedation which is needed during certain procedures like a dentistry, like an ENT, in pediatrics and geriatrics as well. ولكن this is replaced by neuro drugs, alpha-2 agonist, which produce very strong sedation with little effect on cardiovascular system, dexmedetomidine. The other drug, baraldehyde, this is the very old. The baraldehyde, of course, it has a very unpleasant taste. It is oxidized when it is exposed to air, and it is decomposed to acetaldehyde. Yeah, it's not used, very limited use, only as last choice in treatment of status epilepticus. Certain types of status epilepticus, when the first line drugs are not effective, baraldehyde can be used to stop continuous attack of epilepsy in status epilepticus. In this case, it is given rectally or intramuscular. And last, non-barbiturates is the meprobamate, very famous meprobamate, a drug of abuse, a street drug, meprobamate. Meprobamate as well, very old. It was used as anxiolytic. Now it is absolute. Maybe with what we should know about meprobamate, it is the metabolite of car-isobrodol, which is a skeletal muscle relaxant. Car-isobrodol is used for relaxation of the skeletal muscle in certain kinds of muscle pain, and car-isobrodol can be metabolized to meprobamate. Of course, this car-isobrodol should be used for a limited period of time. If it is used for a long period of time, this will lead to accumulation of meprobamate, and this accumulation of meprobamate can result in many side effects, including tolerance and dependence. Of course, the car-isobrodol, it is one of the drugs which can be abused. Okay? Yeah, this is all about sedative hypnotic, whether they are barbiturates or non-barbiturates. So in summary, I can say we talked about the barbiturates and their classification according to the duration of action. We said that they act as the allosteric agonist on the GABAA receptors, especially on barbiturate receptors. In low doses, they increase the frequency of chloride channel opening. In high doses, they can open directly the chloride channel, and that's why they produce general anesthesia. Kinetically, we have said that they have high lipid solubility, therefore they have high access to the brain, they produce quick onset. They are metabolized by oxidation in the liver, and they are very strong enzyme inducer, and this is the reason for their metabolic tolerance if they are taken for a long period of time, and as well as a site of drug-drug interaction. Dynamically, we have said they can produce sedation accompanied by anxiolytic effect and euphoria, and we said that the euphoria is the basic for the psychological dependence. They can produce hypnosis after sedation, and this hypnosis is characterized by depression of REM sleep, and we said that if we stop taking the barbiturates, يحصل rebound, increase in REM sleep, and this will result in the person will go back taking the drug for a longer period of time. Of course, we increase the dose, they can produce general anesthesia, coma, and death due to medullary paralysis. Barbiturates, they can produce tolerance, which might be a kinetic or dynamic tolerance, and they can produce dependence, which might be physical and psychological dependence. They are either used as intravenous general anesthetic or pre-anesthetic medication, and in certain forms of epilepsy, especially status epilepticus, اللي هو continuous attack of epilepsy. Non-barbiturates, we talked about chloral hydrates, and it is very restricted use as procedural sedation in pediatrics and geriatrics. Baraldehyde is only kept for resistant status epilepticus. Meprobamate, as we have said, very little place except it is a metabolite of car-isobrodol. So this is all about sedative hypnotic. At the end, I will say, لله الحمد من قبل ومن بعد. I would like to thank you very much for your attention and your patience. Our next presentation, inshallah, will be about ethanol. شكرا لكم على حسن الاستماع. الرجاء لا تنسوا الاشتراك في القناة، الإعجاب، التعليق والمشاركة مع الزملاء. دمتم بخير وعافية، والسلام عليكم ورحمة الله.